All right, everyone, it is 9:30, so we will work on getting this session started just so that we stay on time and have ample opportunity for the presentation, as well as all of your questions after the session. I'm Sarah Krasaniak. I'm going to be moderating the session today, and I'm really excited to have Dr. Bollier and Dr. King here from The Ohio State University. They're going to be giving a presentation today on micro-teaching methods. So feel free to put any questions you have in the chat, and we'll also have some time at the end if you want to save them for the end. So with that, I will turn it over to our presenters.
Fantastic. All right, welcome everybody. As she mentioned, my name is Allie Bollier. I'm a current first-year medical education fellow at Ohio State. And I will be presenting short on time, high on value, micro-teaching methods to engage your learners on shift with my fellowship director and associate program director, Dr. Andy King. Today we have no disclosures. For our objectives, we're going to summarize the importance and unique challenges of teaching in the emergency department, distinguish factors that contribute to a positive learning climate, apply micro-teaching techniques, including a couple different models, and then determine which micro-teaching technique is best utilized in the emergency department. We want to open the session with a poll. So if you could put in the chat, what have your challenges been teaching in the emergency department? And so we'll give everybody, a minute or so to put your responses into the chat. Perfect. So seeing time, limited time, various learners and skill levels, scaling up for senior learners, right? Patience, skill level, perfect. Being engaging, right? All the distractions, consultants, codes that happen. Perfect. So we're hoping today that this didactic session will give everybody a few new tools to really help your learners on shift and help you guys as well. I think the one thing to start with is just to spend a little bit of time talking about learning climate. So broadly defined, learning climate is the tone or atmosphere of the teaching environment. This includes both the physical and emotional environment, as well as the interactions between the instructor, learner, and content. And these interactions occur within a specific context, such as teaching in the doc box or an interaction with learners and a patient at bedside. And so today we're going to touch upon 4 different concepts, and these are respect, stimulation, learner involvement, and limitations. Starting with respect, there are a few things you'll want to do with each learner to improve the learning climate, and the first is to meet the learner. So knowing someone's name, background, and skill level really goes a long way. Is this a first-year medical education or medical student on their first day of a preceptor program, or an off-service medicine resident interested in critical care? What are their interests? What do they hope to get out of the session? So this is really going to help you tailor your teaching to their level and needs. Another important aspect of respect is the creation of a safety statement at the start of your encounter. And this could be something like, we're all here to learn today. There are no silly questions or penalties for not knowing an answer. So setting this expectation early will really ensure your learners feel comfortable with sharing what they do and do not know. The next concept is stimulation. Another way to look at this is how to keep your learners engaged. So in the clinical setting, the most common places teaching occurs are going to be at the bedside or in the charting area. So here you can think about ways to vary your presentation style to keep learners engaged, such as using a whiteboard or maybe post-it notes to emphasize various points. You really want to show enthusiasm for your topic, explicitly state why you're interested, why is it important, why should your residents and students care about what you have to say. And this will, cue the learners in to stay engaged. Our next thing that we're going to touch upon is learner involvement. So oftentimes, as mentioned previously, there's learners of various stages rotating through the emergency department. You have your first-year medical student all the way up to your supervisory senior resident. There's a wide array of medical knowledge and experience. So when taking the time to dedicate on shift to teaching, you want to make sure all your learners feel welcome to be part of the conversation. By focusing on one learner, other learners may lose interest and do that slow swivel back to their computer screen. To combat this, very eye contact and questions around the room. Start with the most general and broad questions for your novice learners, and then probe your senior learners to fill in the gaps using evidence-based medicine and their prior experience. Lastly, to keep your learners engaged, be an active listener, encourage learners to participate in this safe environment that you've created, and this will really allow you to involve all learners in your environment. The last thing I want to touch upon is limitations. So it's important to know your own limitations as well as the limitations of your learners. To create a safe learning environment, you really want to be transparent and admit to your own limitations. And this could be a phrase to set the tone of a conversation. You know, when I was an intern, I struggled with this. So you want to acknowledge your own limitations as well as the learner limitations. You know, I know this is your first day in the emergency department, and I don't expect you to have all the answers, but I do expect you to stay engaged. And as mentioned, the last limitation is timing. So when is a good time to fit in teaching? You know, with constant interruptions from traumas, code strokes, consultant callbacks, it can be difficult to fit in micro-teaching sessions on shift. So acknowledge to your learners that there may be interruptions, but hopefully the next strategies we discuss will help keep your learners engaged. In terms of micro-teaching, we're going to talk about the following strategies. Micro-teaching is defined as the approach to teaching a general principle in 5 minutes or less. We're briefly going to touch upon the 1-minute preceptor, SNAPS model, illness scripting, and the procedure model. And as we go through each one, please feel free to share your prior experiences in the chat. You know, what's worked well, what could have gone better. In addition, if there's a model that you use that you really like, please share it. I think we're all here to learn and would love to hear about it. Our first model is the 1-minute preceptor. So this is a preceptor-driven model, and it was designed actually for use in the outpatient setting. And although it was designed, you know, for the ambulatory setting, we can still use principles from it in the emergency department. So we'll go through this and give some examples. So the first step in the 1-minute preceptor is to get a commitment from your learner. So after listening to a presentation, identify where the student or resident could make a commitment. Depending on the stage of the learner, this initial question will vary. It could be something like, what do you think the diagnosis is? To, do you think this patient will be admitted or discharged home? Does this patient need an A-line? The next step is to probe for supporting evidence. What do you think? Why do you think this patient requires admission? What evidence can you use to support this? And after assessing how much they know, teach a general principle. If the case is related to chest pain, consider utilizing the heart score, explaining how we use clinical decision tools. And then your next steps are going to be to reinforce what was done well and correct for any mistakes. So within a few minutes, you've assessed the learner's level of understanding, taught a general principle, and given direct and appropriate feedback. If you're short on time, consider having the student or resident review the general principle on their own time for discussion later in shift. Another way to utilize this model when short on time is to truncate the model. You could say, you know, what do you think is going on and why? And then focus on self-directed learning by having the learner take a few moments to look up a general principle before picking up another patient. Our next model that we're going to talk about is the SNAPS model. And so the biggest difference between the 1-minute preceptor and the SNAPS model is that the SNAPS model is driven by the learner. So they're really dictating this encounter and what they want to get out of it. In this model, the learner is going to briefly summarize the history and physical exam, narrow the differential to 2 or 3 relevant diagnoses, analyze the differential by comparing and contrasting those diagnoses, probe the preceptor by asking questions about uncertainties, difficulties, or any alternative approaches, and plan for management of patients' medical issues. Finally, they'll want to select a case for self-directed learning. And how would this look if you were the preceptor? So you'll have maybe a medical student who can briefly summarize a patient coming in with shortness of breath. Then they can narrow out and analyze different differentials such as pneumonia, PE, or COPD. The student will then land on a diagnosis and probe the preceptor for further information, such as, you know, how would you determine if this patient is safe for discharge? And then they'll review their intended management plan and a case-related topic, such as antibiotic choice for pneumonia. If you intend to use this model as it is learner-driven, I recommend giving a copy of the model to the learner at the beginning of shift so they have clear expectations. I think this model is great for students and novice learners as they can take time on shift for self-directed learning when things get busy. And I'm going to pop in the link in the chat to this model to give to your students.
All right. Thanks, Allie. Moving on to our next sort of micro teaching strategy. It's a little bit different than the previous models that were mentioned by Allie. So we're going to talk a little bit about illness scripting. So a lot of what I learned about illness scripting comes from Dr. Saurabh Khandelwal, who's on the session right now. But illness scripts were initially kind of designed as a way to help enhance clinical reasoning skills, basically at the medical student level. But we use it a lot in our program at the resident level as well. So an illness scripting is kind of like mental cue cards that are used to represent specific disease presentations that our learners see in the emergency department. And each illness script is composed of three specific factors: the epidemiological factors, the signs and symptoms of disease, and the pathophysiology of that specific disease process. And how do physicians use illness scripting? So at the various levels of novice, intermediate, expert level. At the novice level, a lot of our learners, medical students, interns, will rely on biomedical knowledge to help explain disease. At the intermediate level, they organize the knowledge that they receive from patients using signs and symptoms to explain a specific disease process. And at the expert level, they create a narrative framework of clinical features to rule in or rule out a differential diagnosis. And a way that we use this is we ask our residents to present the various presentations that they see in the emergency department using illness scripts. So let's say they have a patient that comes in with right lower quadrant abdominal pain and they're concerned about appendicitis. We ask them to present it in a way that is in an illness script format. So the epidemiological factors, so the patient's age, race, if it's indicative or pertinent to the case, gender, if it's pertinent to the case, and then any specific risk factors that they may have for this specific illness. Followed by the pertinent information in regards to signs and symptoms that were shared by the patient, and that includes physical examination, and then the pathophysiology that suggests what's going on and what is kind of lending to their differential diagnosis. And then once they present their specific illness script, we have them present their differential diagnosis and plan, and we have our specific discussion about the patient's case, and the attending provides some additional insight on their illness script for the specific disease process that the resident's concerned about, et cetera. So the next model we're going to talk about is a procedural model of teaching. So this is an area that, as we're seeing, we saw in the responses that you guys put in the chat that a lot of the issues with teaching our residents is time, is too many patients. So a lot of us have a hard time spending time in the room supervising a procedure from timeout to cleanup. So one way to kind of spend a couple of minutes in the emergency department before a learner's about to embark on a procedure is to go through a kind of stepwise approach to teaching a procedure. And first, the first step is preparation. So you want to prepare the learner, you want to prepare the patient, you want to prepare the environment. So that's getting everything ready. That may be inviting the learner to go through some self-directed learning activity where they're reviewing the procedure quickly in Roberts and Hedges. They are reviewing a YouTube video, etc. Then you want to sit down with them and you want to review the specific indications, anatomy. You want to conceptualize that specific procedure. Then you want to work together and visualize the procedure. And that could be through watching a procedure video in its entirety, going back and kind of focusing on the different aspects of the self-directed learning exercise that they performed in the preparation step. You want to have the learner verbalize the important steps in the procedure before embarking on the procedure. And then another way that you can do this kind of outside of the emergency department is to provide guided supervised practice. And you want to make sure that you're providing pretty immediate post-procedure feedback. That's important to the learners for further improvement.
Perfect. So in summary, we discussed the 4 main concepts of creating a positive learning climate, including respect, stimulation, learner involvement, and limitations. We reviewed the 1-minute preceptor model, which you can truncate depending on time and utilize self-directed learning. We discussed the SNAPS model, which is learner-driven. And because this is a learner-driven model, consider giving the student a copy of the model at the start of each shift. Finally, we reviewed illness scripting, which is the creation of mental cue cards for specific diseases, and the procedural model, which is a succinct way of conceptualizing, visualizing, and verbalizing the necessary steps before performing a procedure on a patient. And remember, in each of these models, there's room for on-shift self-directed learning, especially when you're short on time. In regards to which model is best, I think it really depends on the time you have, the number of learners, and the level of your learners. If you're short on time, you can pick and choose the pieces of each model which you find most valuable. And so we really hope that you found this review of optimizing learning climate and micro-teaching techniques useful for your clinical practice. So we want to thank you for being here and open it up for any questions.
We know it was quite a whirlwind to go through these sessions or these different techniques so quickly. But so if you have any questions, we have a couple minutes that we can address them.
So while everyone's thinking of their questions, this is a fantastic presentation. And I think that, certainly these address some of the time issues in terms of, even just giving us a structure to use, which is nice because I think it can feel a little bit overwhelming just to know where to start. I like, one of the questions I came into this presentation with was really how to scale this up. I feel like it feels much easier to teach that medical student and intern because you can really take a deep dive into like differential and what else it could be. Whereas the senior learners have like gone through that, especially now in May, where we have 4th years that are getting ready to graduate. So I like that, Andy, what you were talking about with focusing on the pathophys, because I feel like even though the early med students and learners sort of know that, we kind of forget that. So I think that's a great way to refocus our senior learners and bring them back to not just like, what's your dispo, how are you going to manage this, but like, what's that pathophys behind it? And it looks like there are a couple questions. So David, maybe if you want to start first, and then Kimberly has a question after that.
Sure. I was just wondering if the more experienced educators here find that it's helpful to ask about a learner's goals at the beginning of the shift. That's something that I sort of had drilled into me during my residency, and I've sort of carried it forward. And I find it's, especially for off-service learners, very helpful because they're not all going to be emergency physicians, and tailoring some of their learning objectives. But what are the more experienced people's thoughts on that?
Yeah, thanks for the question, David. I think from my experience, I do think it's very useful for off-service rotators. But I think kind of as you get to work with the categorical emergency medicine residents more frequently, I tend to maybe let that kind of trail off a little bit as I get to know them more and I kind of know their strengths and opportunities for improvement, and I kind of aim my teaching at kind of where I see opportunities for their growth. But I definitely, I certainly, with the rotators, I don't know them, so I think it's important to ask them and engage them on what they're looking to get out of their rotation. Hopefully that answers your question.
Andy, we have 1 minute left. So Kimberly Schertzer had asked about signposting, especially when using the SNAPS model, and how do you have, help learners realize that like teaching is occurring?
Yeah, I think with the SNAPS model, it's important to have buy-in from both sides, right? The learner and the attending on shift. And so when you're going through the model pre-shift, can discuss how it's learner driven, but that the attending is there to provide the expertise and the guidance, but that we want to tailor the teaching to what the student is interested in that shift. So I think kind of clarifying goals and expectations at the start of the shift, if you're going to use the SNAPS model, is really important.
Excellent. All right, we are right at 9:50, so perfect timing. We will stop there, but please reach out to Dr. King and Dr. Bollier if you have more questions. And thank you guys very much for this session. It was really wonderful. Thank you.
Thank you, everyone.
Thanks, Sarah. Thanks, everybody.